Hello and welcome to a new episode, but also a new season of Majlis podcast by Emirates Hospital Group. I'm Wael Berro. I'm a family medicine consultant at Emirates Specialty Hospital. And today we're going to start the new season with my colleague Dr. Ritesh, who's going to talk to me about pulmonology, lung disease, and especially interventional pulmonology. Dr. Ritesh.
Hi, I'm Dr. Ritesh Sharma. I'm working as a specialist pulmonologist at Emirates Specialty Hospital. It's been like 13 years of experience in interventional pulmonology, including most of the topics like bronchoscopy, then EBUS. Then you must have heard about the pleural procedures that we are doing through ultrasound guided things. This interventional pulmonology is very specialized field that actually focuses on diagnosing and treating some lung conditions that are requiring minimal invasive procedures. It's a special interest that I developed when I was working in India, and I worked with the most prestigious hospital in India that is called Tata Hospital. It's in Mumbai, and there we used to see a lot of patients who had suspicion of lung cancers. So in those cases, we started my training, and there I learned doing interventional procedures like bronchoscopy. We were doing biopsies. There would be like CT-guided biopsies and bronchoscopy guided biopsies that we called as transbronchial lung biopsies. And with it, I learned actually doing thoracoscopies. And nowadays, another term can be pleuroscopies for that. In cases we have a lot of cancer patients suspicion of having a lot of pleural effusions. So that's how I developed my interest in interventional pulmonology. And I'm thankful working with Emirates Hospital and looking forward for it.
Yeah. Thank you very much for your time, and it's a privilege and honor to have you here. And welcome back to the group,
thank you
because you were with us before.
Yes.
Now, we are moving into an area of minimally invasive, and technology is evolving. And you eloquently described the role of an interventional pulmonologist. What are the conditions, though? Because you mentioned the procedures and the techniques, but as a patient, and if I have a certain lung condition, when should I see I don't want to say standard or traditional pulmonologist, but someone who's a bit more interventionist, and what are the conditions that usually also as a family doctor, I refer to you for treatment?
I would like to go by step. In this case, the most common presentation that a patient should be referred to a pulmonologist or they should come to a pulmonologist comes with a simple symptom that is called cough. So if patient is having a cough that is not going like for weeks or a month, then in that case, I think they need a detailed investigations. The investigations, they start from the radiological part, like that can be X-ray, they can be CT scans. And then if we are not able to find anything in that, then the next step goes towards a bronchoscopy. Some patients who has got chronic cough, in that conditions, if we go ahead with the bronchoscopies, in that cases, we are able to diagnose what is exactly the reason for the cough. Some patients, they have hyperactive lung conditions. Some patients, they have foreign body impacted inside it. That can be reason for the cough. That is most common. And especially in the kids that usually come like age of 10, 12 years or 14 years. In that cases, there can be the most common thing is the foreign body that can go into the airways because it's the most common thing. Some patients who experience one-sided sound from the chest, that usually in the medical terminology we say it as a wheezing. So if they are hearing a sound unilaterally from one side, then definitely there can be a possibility that there can be a foreign body. And if the patient is experiencing recurrent infections, recurrent visits to the hospital, recurrent I can say treatment for the antibiotics, and especially the color of the phlegm, that indicates us that yes, there is an infection or not. So I believe that if patient is having yellow colored phlegm that is coming from the on the mucus, and secondly, if it is a green color, then definitely the patient should come to a pulmonologist, and then we can evaluate them accordingly. The thing that you asked, like what are the things that can lead to more interventional pulmonology things? Some patients who have suspicion, as I told, lung cancers. So lung cancers is the thing that needs to be diagnosed in the early stages. So if we are suspecting lung cancers, if we are suspecting any airway tumors, if we are suspecting some lung nodules, in that case, interventional pulmonology plays a major role. In that cases, we have bronchoscopes through which we can go into the lungs. We can see the airways, and we can proceed with biopsies that is called transbronchial lung biopsies if we find something in the airways. If there is something inside the skin of the lung, I'm just simplifying for the audience so that they can understand what is bronchoscopy and how we do it. It is just a simple tube in which there is a small camera is fitted over it, and just we go inside the lungs and we see what is exactly inside the lungs. It's just like programming the inside of the room, that how we can say. And if we see something inside, like some mass or some mucus collection, that can be a foreign body. So we go very close to that, and then we try to either suck it out or we try to take a biopsy of that. Some patients who have got lung nodules, and if we see any lymph nodes in the CT scans that we are doing, that can be suspicious. So for that, we have transbronchial needle aspirations. Nowadays, a more advanced version of bronchoscope, I would say, that has come a combination with bronchoscope and ultrasound, that is called EBUS, endobronchial ultrasound. So that is the recent thing that we are having with us, luckily. And in this, it is a bronchoscope with a camera and an ultrasound that helps in reaching us to the places and with less complications. Because doing these procedures, it is minimally invasive, but there are chances that we can, because the area is surrounded by heart and it's a major blood vessels. So if we are doing any transbronchial needle aspirations, if we are doing any transbronchial biopsies, we may land up in some problem. But with the help of this EBUS and endobronchial ultrasound that I explained, the complication rate has gone very low, and we are able to diagnose conditions like in the start for the lung cancers. Now coming to the patients like who has got airway problems. So some patients, they hear sound from the chest. So it is sometimes they are called the airway problems, and it can be tracheal stenosis, that is congenital sometimes. Some patients, they have bronchomalacia, we say, and some patients we have tracheomalacia. Tracheomalacia is small, the collapse of the trachea, the windpipe that we have. So these conditions can be easily visualized using these bronchoscopies, and if required, we can do the treatments in the form of stentings. That is more commonly done nowadays. And if the patient, we see that there is a stenosis, in that case, we easily put a silicone stent inside it, and the condition can be easily treated. So it's so wonderful and like interesting field that I'm used to enjoy it, and I'm grateful that we are doing here in Emirates Hospital, and we have done a lot of procedures like that, and a lot of patients have got benefit of that. Yeah.
And I have no doubt. And like you mentioned, the advantage of such procedures, and if you think of it from a micro level, at the patient level, they don't have to come one time to do the diagnosis, go home, wait a few days, come back for the treatment. So you're combining the diagnosis, the treatment in one session. And that's, I'm sure it's a blessing for many.
Yes, exactly. Because, cough is a symptom that annoys everyone, even if it is with us and even in the family members, it is definitely a concern for everyone. And if despite of the treatment, the things are not getting better, definitely it becomes a major issue in the families. And when the patient comes to the hospital, to a doctor, we know that he has got his mental concerns, he is anxious about what exactly is going in, and we have to combine a proper counseling and the treatment procedures for the patient so that it helps in them. And I'm glad having these advanced medical things that we have now in the present world, we are able to treat the patients and make them comfortable and make them happy. And definitely the lifestyle is changing because of new things. Yeah.
If you can make my patients happy, I'll be very happy. So I'm going to send you all my patients then.
Thank you very much.
Now,
pleasure to that. Yeah.
As a family doctor, I deal a lot with chronic conditions. And when I combine chronic conditions with your field, we're talking asthma, COPD.
Yes. Yeah.
Can you tell me what is the role of intervention pulmonology now? Yes. Is there actually a role for it?
Yes.
And what is it, if that's the case, when it comes to managing these? COPD is emphysema, and for the audience, chronic emphysema, and asthma, everyone knows it. So,
yes, Dr. Wael. I would just like to make it a little bit more simple so that the audience understand what exactly is COPD. Usually, if the patient is having a history of smoking, and the patients who have old age, we see that they have long-term coughing, they have breathing problems, they bring out phlegm. So usually in COPD, we have two type of procedures that is going, the pathways exactly, in which the most important is our muscles that are inside the air pipe, they get thickened up. So the role of interventional pulmonology comes there. And in some patients, we have emphysema that you already told. Emphysema is the permanent dilatation of the airways. So we have two type of treatments in that. One is called bronchial thermoplasty. In bronchial thermoplasty, very simple for the audience to understand is we just try to burn the excessive muscles and just to increase the area so that the airways, they get to normal, healthy part, and the breathing patterns can be easily restored. Secondly, coming towards the emphysema, we have endobronchial valves. So endobronchial valves, when we put in inside the lungs, we reduce the lung volumes, because in COPD, the lung volumes, there is an increase in the lung volumes. So when we use endobronchial valves, they are actually one-way valve. So it decreases the lung volumes. So we have seen a lot of patients who have underwent bronchial thermoplasty and endobronchial valves. They have the lifestyle, the quality of life has increased, like it has become better, and the chances of getting exacerbations, the frequency of visits to the hospital, that has reduced, and definitely the respiratory infections have come down. And nowadays it is done very commonly, and it's a regular procedure, and a lot of new endobronchial valves and the bronchial thermoplasty is going nowadays. Yeah.
And that's very nice to hear and to know, actually, most importantly. Are we talking one session, or they have to come few sessions?
It depends upon the level of muscle hypertrophies, and usually it is done in the one setting only. And if it is required, then it requires like every session after 3 to 4 weeks. And especially in case of endobronchial valves, we need to assess them regularly by doing bronchoscopies. If we see that still the valves are not in a proper position, we have to repeat it again. But usually the success rate is almost 99%. So I would say that yes, it can be done in the first setting only.
Yeah. That's an impressive success,
yes,
right?
Yeah.
Now, another chronic condition very close to my heart as a family doctor, because I talk a lot with my patients about their sleep hygiene, their sleep pattern. And when it comes to certain sleep disorders like obstructive sleep apnea, we find that in the last couple of decades, the technology didn't catch up. We used to say, okay, that's it, you'll end up with CPAP. And from a patient perspective, it's a nightmare.
True.
And they usually have to pick between having a machine loud or being tired and having symptoms of sleep apnea. Tell me, please, how are you helping those patients now?
Sleep apnea, as you said, Dr. Wael, it was usually under, you can say, since last 7 to 8 years, it's more in the discussions and more awareness among the people. And we are happy to see that the patients are coming to us in the OPD with the complaints of their disturbed sleep patterns, especially the partners when they come with their family. They explain how worst is the sleep and how much disturbance that can cause in the family, like the next partner who's sleeping next to them. So usually we all know that the patient who has got snoring, the patient who are obese, usually the obesity we measure by BMI. So if BMI is more than 25 and it goes up to 35, 40, and we see that a lot of population here in Dubai is having BMIs more than 30. So these patients who has got obesity, BMIs more than 30, who has got short stature, who has got short neck. So in these patients, yes, they are prone to have a condition known as obstructive sleep apnea. The most common symptoms will be they will be having a disturbed sleep, they will be waking up many times in the night. The excuse can be that they have to go to the washroom. We have to judge from their history that we are coming in. And then they wake up in the morning, they have morning headaches, they have excessive daytime sleepiness. And whenever they drive, they feel sleepy. And if they are going out for any public places, like they for a movie theaters, then yes, they feel sleepy and they can doze off. And it definitely affects their mood disorders. It calls, we say that they have mood disturbances, like they can be more angry, they will be reacting like any weird way. And especially they have, if they are married and if they are sexually active, definitely it affects the libidos. So this problem has definitely a concern, and it is called as the iceberg of the diseases. And I believe due to sleep apnea, a lot of conditions like heart conditions like hypertension, then MIs, usually we hear about the silent MIs. So the most common reasons can be sleep apnea. And in the patients who have these problems, we definitely, interventional pulmonologist can help in that, like what can be the reason for the sleep apneas. Definitely the assessment starts from the physical examination. When the patient comes to us, we start seeing their, first of all, the nostrils, definitely if they have a deviated nasal septum. So we assess them, and if we found it, then definitely we have a team from the ENT that helps and supports us. Then we see the jaws. Jaws are the most important thing in that. If the patient has got small jaws, if there is retrognathia, if they have any history of any accidents or something, so in that case, we start to assess them. Now, coming to the role of interventional pulmonology in that, definitely there is a collapse of the airways when the patient is sleeping. So we have to find, especially if there is any specific area where there is any airway collapse. So what we usually do is it is called drug-induced sleep endoscopy. We just give the patient a little bit sedation, then we do a bronchoscopy in that case, and we try to see if there is any specific area where the airways are collapsing. So again, as I told you previously, that if the patient has got some tracheal stenosis, definitely that means there is an airway collapse. So in that cases, we can put some stents inside it, which says tracheal stents in that, and that's how we can go ahead in that. And especially the patient who has got other conditions like tracheomalacia, then brachymalacia. And so all these cases, yes, the interventional pulmonology, they help in that. And the patients who have like more problems, even without doing all these things, if they're not improving, then in that case, we have to reach to the tracheostomy if they have got severe sleep apneas. And as my experience, we have like daily, we are seeing almost 3 to 4 patients who have got sleep apneas. It requires actually a combined team approach, starting from the counseling, explaining them the conditions and how it will be treated. And yes, CPAP is a concern for everyone. So it definitely, we focus on reducing weight also, because obesity is definitely a concern, and a lot of options nowadays we have, invasive and non-invasive ways to reduce the weight. So it contains like full counseling accordingly. And I believe listening to us, it makes patient more comfortable. And yes, there should be anxiety about it, but the fear goes down when they speak to the specialist.
Perfect. Yeah. And thank you for mentioning obesity, because it's a dear topic to my heart. And as a family doctor, I always believe that lots of these chronic conditions is a joint effort between the specialist and between the family doctor in a way. And most important, having the patient at the center of the care. Dr. Ritesh, it's a pleasure. I mean, we can talk forever, I think, about your field, and I can see how passionate you are. But thank you very much for summarizing this. For our audience today, take-home message, please.
I believe we should focus on our lung health. Lung health is definitely more important for us to have a life that, in that case, we can enjoy for like a healthy lifestyle. So if we have got some allergies, if we have got some conditions like we have coughing, and we have to focus on something is like if we get some blood inside the cough, so definitely these are the alarming signs. And if you have obesity, we have to see for the sleep apnea problems. And the patients who have COPDs, who have got any type of chest pains, and chest pains can be due to pneumonia, it can be due to pleural effusion. So we have to evaluate it. And yes, believe me, if we reach the hospital, if we meet specialists, then definitely the things can be treated early. And yes, lung cancer is again a concern. And I would like to focus on most important thing is smoking. So I would request my audience to think before you smoke, because smoking is the most important risk factors for all, like almost I say 50% of the lung conditions. So I believe the audience will listen to us, and they will be having a better lifestyle. Thank you.
I hope so, and thank you. And we always say prevention better than cure. Early detection is part of the cure. Look after yourself. This brings us to the end of our session today. Thank you very much, Dr. Ritesh. Please stay tuned for a new episode of Majlis podcast very soon.
Thank you very much. Thank you.